Well, good afternoon, everybody, and a very warm welcome. Thank you for sparing your time this afternoon. So our webinar today is on 24 hours postural management in complex disabilities. There's a lot in that. I'm looking forward to it myself in terms of learning we can get from this. So this is a webinar with Shiva Jamwal, Head of Therapy Services, a consultant occupational therapist at the Royal Buckinghamshire Hospital. So thank you very much, Shiva, for joining us this afternoon. So just briefly, before Shiva kicks off, just a few things as to who we are. So Yorkshire Care Equipment, our mission to enhance quality of life. So that, I guess, will really resonate with everything a lot of you guys who've joined do each and every day. We've got equipment in varying marketplaces, including hospitals, such as where Shiva works, and then other care facilities, be that nursing or residential, and in many private homes as well across the UK and abroad. So we were established in '72, and this year it's our 50th birthday, which is something to celebrate. And way of celebrating, we've come a long way since 1972, when we were very much focused around the Yorkshire area. So we've transitioned. So as of Monday, we become Vivid Care. So from Yorkshire Care Equipment, exactly the same people, for those of you who deal with us, but just really a refresh, a reset, if you like, at 50 years. So we're now Vivid Care. Just briefly, in terms of equipment, which I feel might relate to what Shiva's gonna touch on. So specialist tilting space wheelchairs, including standing wheelchairs. They're just a few from our range. And then we have a very wide range of specialist seating. So tilting space care chairs through to your rise and recline chairs, be that for pediatric or your bariatric patients. So with that, a very warm welcome to Shiva, and looking forward to it. Thank you, Shiva.
Thank you, George. So I will share my screen. Hello, everyone. And we get started. 1 second, 1 minute. There we go. I hope everyone can see my screen. Good afternoon. Today is the session. I'm giving a talk on posture management in complex disabilities. We would be talking about, obviously, complex disabilities and the effect on an individual's posture, goals in seating and, so a second, please. Sorry, I'm just checking my screen. Goals in posture and seating management. What is a normal posture? Consequences of neurological injury and the effect it has on an individual and eventually his or her posture. Secondary complications as a result of a bad posture, and 24-hour posture management. What is it and what can we do? So my name is Shiva. I am an occupational therapist, and I lead the therapy services at a private hospital, which specializes in neurological conditions and spinal cord injuries, brain injuries. So, and I'm also a qualified seating therapist. So let's begin with, what is a normal posture? So posture is a constant struggle to remain upright against forces of gravity, which we will see in the subsequent slides. The struggle that we go through every minute, fighting these forces. Posture is a series of positions through which we function. We have numerous postures during our working time, during sleep time. And you can see at the bottom, there are different postures. I never knew even there are names for those postures, and I'm sure we all can relate to one of them. I'm certainly a hipster posture. So, but what we need to know, and I'm sure most of you are working with individuals with disabilities, some in neurology, some in orthopedics, but the fundamentals remain the same in how we manage a complex posture. So a good posture must facilitate maximum performance with minimum expenditure of energy. But before we go on, we need to understand what is a normal posture and what is a postural alignment, because that's our baseline. And then we work through a problem-solving process in suggesting and providing a suitable seating and posture solution. So posture is alignment of our key body segments: head, shoulder, should be neutral, the curvatures of the spine, the cervical spine, the thoracic spine, lumbar, sacral, alignment of pelvis, alignment of the legs, thighs, knees, and most importantly, the center of mass. Center of mass is a theoretical point around which the weight, the mass is evenly distributed and gravity is equal all around. So it is around S2 level, and which is in between the pelvis. So when we do a posture management, this is what we look for. The center of mass, it should be within the our base of support. So if the center of mass, for a reason which is disability or any disability, or not even disability, even the weight has moved away from where it is, it asks for a lot of energy expenditure and the compensation that happen as a result. The forces that we fight every second. Posture is basically the equilibrium of all these forces. Gravity, which pulls us down. Ground reaction forces, which is the force provided, the upward force provided by the surface in contact. Not only that, there are internal forces, our muscles, which muscles, tendons, bones, they all provide a force, an upward force against gravity. So we have the extensor muscles, which are anti-gravity muscles, the key muscles that hold us upright. And then in addition to that, there are external forces that we have. For example, whatever surface we are sitting on, the orthotics anybody is using. So these are all the forces, and when they work in harmony, we get a good posture, we get a balance. But what happens when an injury happens? These are the forces that we need to bear in mind when we provide a solution. So in addition, as I said, there are the buckling forces, the ground reaction forces, the friction force that our patients face when we seat them. It's a stopping force to any movement, shear force on soft tissues, torsion, which is the rotational force, pressure, which, as you can see in the subsequent slides, how much pressure causes a distortion, causes strain or stress to the muscles and soft tissues. And when these forces are unbalanced, it causes instability. So imagine this big rock, which is just at the cliff. This is how our patients feel when they have weakness, they have paralysis. This is how they feel when they have to sit upright in a chair. So I thought this is a nice picture to show. And I would just share my experience with one patient who had no trunk control and was on a normal wheelchair. So all she was doing for years was holding onto the armrest of the wheelchair to maintain sitting. And then eventually the arm had contracted. So I could very well relate to this picture with her, because this is how she was in the chair. So thinking about these forces, thinking about the equilibrium and what happens when these forces are unbalanced. This is just a cute factor in the presentation, that when we move into different postures, we have the ability to bounce back into shape, but our patients don't, with whatever condition they're going through. And that is what causes disbalance of the forces. That is what causes asymmetry as a consequence. So if you think of agonists and antagonists, which are the muscle groups, and they are holding the spine, the pelvis, in a very balanced way, in a normal aligned posture. When any neurological insult happens or orthopedic injury happens, this alignment is disrupted. And so we see, as a result, we see asymmetry in posture. The pelvis is dropped, the trunk follows, the head is dropped. And head and shoulders, it's quite a key segment, which altogether carries 20% of the body weight. So these are the two elements which we'll talk about later are also key segments that determine how our posture, how an individual's posture is. So when an injury happens, a neurological insult happens, what happens to the physiology? There's a motor and sensory changes, paralysis, weakness of the muscles, atrophy of the muscles, sensory changes, loss of sensation, loss of proprioception, pain as a result. And there could be cognitive and perceptual deficits as well, which also determine how they sit. It could be a unilateral neglect. It could be body awareness, spatial awareness. And in addition, tone and spasticity or any contractures, deformities that they may have. All this leads to reduced mobility, so they cannot come back to a normal posture if there's a displacement, causes asymmetry, poor balance and stability, leading to deterioration in the postural alignment we talked about earlier. And as a result, what do we get? A complicated posture, an asymmetry, which can result in contractures, deformity, reduction in function, reduction in quality of life, pressure sores. So these are the two examples I picked up, and these are from my clinical practice. The patient on the left, and you can relate from what we spoke earlier, complex deformities. The person on the left has been a wheelchair user for 65 years. And this is what has resulted. She is amazingly still functionally independent, and she does slide board transfers. But her posture is awful. So you can see the pelvis is dropped and it's fixed there. We couldn't do anything. It's rotated. We can't fix it. We can't reverse. As a result, she had a double scoliosis, an S shape. Her knees were contracted. Feet were contracted. So this is how she presented, and we were trying to build up and accommodate her asymmetries because we couldn't correct them. But she had to function. That was her main goal. She had to continue to function, and she lived alone. This was an amazing example. But as a result, what had happened? She had a compromised respiration. She had compromised bowel and bladder, which was not related to her neurology. It was related to the postural changes she's gone through over the years. Poor digestion, which resulted in poor bowel management. The patient on the right is surprisingly an acute injury, and he was a spinal cord injury, and he came to us 6 months after his injury. But this is how he was positioned in whichever hospital he was. So he had developed a deformity of cervical extension. So you can see that, and we could not correct it. And he had contracted elbows. He had contracted pelvis, which was in posterior tilt. So he had basically taken the shape of the tilting space he had. So my point here is that it could be 65 years or it could be 6 months. The deformities, the contractures can set in if not managed properly. So what are the secondary complications, which I have just touched anyways? Pain and discomfort, of course, contractures and deformity. So our body is amazing. It just takes the shape of wherever it is static. So like in the examples earlier, if individuals had been in that position for hours in a day, over the years, the joints lose their range and they become tight, the muscles become tight, and joints lose their flexibility, they're contracted and then eventually deformed. Fatigue, because obviously it compromises, it's a struggle against gravity. So the forces we talked about, constantly struggling against those forces to keep them upright, leaves the muscles tense and fatigued. Moreover, it compromises the respiration, because for our internal organs to function, they need to be in a properly aligned manner, which is what our skeletal system, musculoskeletal system does. Compromised swallow and digestion, same reasons. Compromised speech. And Lastly, these are just the key. There are so many consequences, but I've just picked the key ones, and I'm sure you all can relate to that. Pressure buildup causing pressure sores. So pressure sores cause NHS 3.8 million per day. This is a recent study, and I'm not surprised. If the posture is bad, or a prolonged posture, whether it is good or bad, will result in pressure buildup. And you can see in the picture here, when the body weight over the bone causes so much tension in the soft tissues. So the body has to move. One has to reposition so that the pressure is evenly distributed and the blood supply is continuous. The shear force, which we need to be mindful of all the time, is the force when a patient is sitting on the forces under the bony prominences, their fight against the soft tissue movement, that is a shear force. When we are seating a person, if there is a movement allowed, which is not voluntary, it causes not only friction, but shear. Moisture, another big cause of pressure sore, because the body regulation is compromised. The repositioning does not happen as frequently. So the epidermis sweats and causes moisture, which makes the skin weaker and causes moisture lesions. So these are the things we bear in mind before we go on to see someone's actual posture. Some of the postural asymmetries, common postural asymmetries that we come across is pelvis tilt into posterior. And most of you, if you are dealing with people in wheelchairs, you will see they come slouched. That is because their posture is posteriorly tilted. And as a result, what happens is the thorax just flexes over it. So you get kyphosis. The hips, as a result, they externally rotate, and the legs externally rotate, the hips, causing the inversion of the feet. So you can see the key point here is pelvis, and pelvis is determining how the trunk is going to respond and how the legs are going to respond. What happens to the head? So if you see in the picture there, the head is flexed forward. And as I mentioned earlier, head carries 8% of the body weight. So it's a big load on a huge lever, which is again adding to the forces a person has to fight to stay upright. Anterior pelvic tilt is another asymmetry that we see. Less commonly though, but yes, we see it a lot. So as a result of anterior pelvic tilt, see what happens to the spine. The lumbar spine has gone into hyperextension, which is lordosis. And what happens to the hips and knees? Hips go into internal rotation, adduction, and as a result, the feet go into inversion. So if we address just the trunk, it's not going to work. If we just address the legs because they're adducted, it's not going to work. It has to be a solution, and we need to understand where is the force coming from. Trunk instability, many reasons in a neurological injury or any other injury, because again, there's an asymmetry of the muscles, and that causes a pull to either side. Now, our bodies are designed in a way that we want to stay upright. We want to make the eye contact. So if in this picture, you can see the pelvis is dropped on the right side, and what is happening to the trunk is it's just rotated over. So if there is a trunk instability, what is happening to the head? Head wants to still come up, and you can see an S-shaped curve happening here. So trunk instability will result from pelvis instability or vice versa. So we have to look at all body segments together as a whole. As a result of asymmetries that we've just seen, they result in high pressure buildup in certain areas where the pressure, where the forces are highest, which in a wheelchair or in a lying position, we'll look at. These are the key points, and I'm sure you, in your practice, you would have noticed some points are more vulnerable than the others. So bony prominences, yes, but also any part that comes in contact with a hard surface is prone to develop pressure or moisture lesions. These are the key points to bear in mind. High risk areas when in lying position. These are normal postures, but think about asymmetric posture and what happens to the areas in contact most of the time with the surface. So what can we do as a therapist? We need to understand body segment alignment in a normal posture. We need to understand the forces that an individual is fighting, internal forces, external forces, the forces which are provided by the supports we give them. We need to understand their injury and its physiological effect, which will affect the postural alignment. And we have to pay attention to all the posture an individual goes through during the day, during night, when they're static, when they're dynamic, when they're functioning. What is their lifestyle? What is their personality? What is their cognition? So it's a whole person, and we have to look at the person that way. And it's not just seating or equipment. And we have to involve the MDT. It's not one discipline's job to manage posture. It is everybody. So we have to involve the MDT for their posture management. We have to involve the family. We have to involve the patient. And we have to continue monitoring their needs, because in any condition, right from the acute to subacute to chronic, and back in the community, they will physiologically change, and hence their posture will change, and the seating needs to be reviewed regularly. So how do we assess? Again, remembering what are the intrinsic factors, which is what is in the injury, what effect it has, what are the extrinsic factors of a postural asymmetry, and we do a thorough, detailed physical assessment. We try to understand the patient, their environment, which environment are they going to go back to, how's their home, what is their lifestyle, age, weight, changes in weight over a period of time, have they lost weight, have they gained weight, there any premorbid condition that makes them vulnerable to not only postural asymmetry, but other conditions, what their occupational roles had been, whether they were a working person and they aspired to go back to work, whether they were a homemaker, whether that was a student. So we need to factor all these in. What is their current function? And most importantly, what is their prognosis? Are they going to change rapidly, or are they going to make slow changes? And patient compatibility. Do they understand what plans you want to put in? Because nothing is going to work if we do not have their compliance, do not have their partnership. So assessment. So we need, this is I would just speak on our practice, and I'm sure all of you have different ways of assessing, or limitations and what you can do, but I am talking about our own practice and what is an ideal way of assessing a patient. So when we assess our patients on the plinth, on the chair, in bed, because it's a 24-hour posture management. So we would get them on the plinth, in lying position, in sitting position, and when we do the assessment in sitting position, it's quite different to how they are in lying, because they're fully supported and they're not buckling to the forces. So it gives us it's a good picture. So during this series, we would identify what things can be, or what asymmetries can be corrected, and they could be just postural because they're just trying to stay upright. When they're in a lying position, they're supported. So some of the asymmetries can be passively or actively corrected. And those that cannot be corrected, we call them critical factors. They are the factors we need to bear in mind to accommodate, because you can't change them. We will do a thorough assessment in their current seating, whatever it may be, a wheelchair or an armchair. This is how they like to sit. This is their postural attitude. And then we make a theory. So this is what I've gone through. And what is their posture when they are doing a functional task? So if they are in the ward, how are they seated? Is the function done in bed? Is it done on a shower chair? Is it done on a wheelchair? We would do a thorough skin check. And believe me, a lot of time we've had patients would say, oh, I have no skin issues. But when you have a thorough skin check, there is a pressure, there's a skin breakdown, which the patients are not aware of. This is not unusual. So it's very important to have that check in this, especially the key areas that we saw earlier. And have a photographic baseline, because sometimes it's hard to write in words. So if you can make a picture, stick diagram, or take a picture that and take some videos, it will help in comparing the postural solution later on. And then we establish a baseline posture. So I've taken this example because this individual came with contractures of both knees, contracture to the pelvis, and as a result, contracture of his feet, ankle. So assessment on plinth, you can see as a wind sweep posture going on here. We've established that the critical factors to accommodate was pelvic rotation, pelvic obliquity, hips and knee contracture, and ankle contracture. So then we start making a story. We start making a problem-solving story. We would provide supports on plinth or on bed, wherever they are, and we'll see how much neutral alignment we can get. So in this case, if you've seen that we have supported the left leg, because this is critical, we can't change if we have to accommodate, and see how the pelvis has behaved as a response. So it is more in a neutral alignment, just with the supports. And this is how the story builds. This is how we would then start looking at seating solutions in lying position, a wheelchair solution, a standing solution, and then make a 24-hour posture management program. I will not go so much in detail now because I have this slide again, and then we can touch that. But these are the things we have to bear in mind, that it's not just seated in the wheelchair. It's all about where are they, how many postures they go through, and how can we help them attain as normal, as neutral alignment as possible. So what are the goals for seating? Maximize stability, so that the energy expenditure in at least static position is minimum, even posture distribution, maximize function, efficient propulsion of whatever seating solution, whether it's a power chair or it's a manual wheelchair or it's a hybrid, minimize and prevent deformity, minimize pressure buildup, maximize comfort, and maximize self-esteem. It has a huge implication on how they see themselves, whether some patients are quite conscious about how they look, and that could be a hindrance in them participating in community because they don't like to be seen in wheelchair, or their chairs are so big and bulky, the posture is so compromised that they don't want to have a look, want to see people look at them like that. So there's a lot of teaching, and that also goes behind posture management. And intervention. So accuracy of baseline postural assessment, optimizing effect of gravity through postural supports and aids, stabilizing pelvis and thighs will provide a stable base of support, address their pressure needs. Most importantly, we have to prioritize their function. So in the picture of the lady I showed earlier, she had been a wheelchair user for the last 70 years. So, 65 years. And we had to prioritize her function because she was living alone with a care package, and she was propelling her wheelchair herself. Her posture was awful, but she could get from A to B independently, and that was important for her. So we had to do a little compromise where we had to, we could not give aggressive supports to her pelvis because that will not allow her to propel. She will not accept power chair at this stage. So lots of education, lots of, in a way, therapists are coaches as well, because there is a way of making patients understand that their needs have changed, so they have to change the outlook. So posture, prioritizing function is paramount. Whatever ability they have, we have to ensure they continue to do that. External supports through specialist seating, and as I said, patient education, family education. So seating is not just about wheelchair. This is the individual which I showed earlier, forming a baseline. So it is again going into 24-hour posture management, how the person lies in bed. So we provided support. If the support cannot do the purpose, then we look for more specialist supports like seating systems. But we try to keep things as simple as possible first to manage, because you have to look at how are they going to manage in the community? Are they going to put the supports or aids themselves? Do they have carers? How much turnover of the carers you have? How many shifts? All these factors need to be considered, because that's where things go wrong. So we might send someone with a pristine postural solution, but in the community, it's just gone out of the window because the carers cannot manage. Looking at this person particularly, we provided a power chair because he had shoulder cuff tear in both shoulders. So he could not propel his manual chair for longer. So it was a power chair. And not only that, 24-hour means he's going to spend 6 to 7 hours in the wheelchair, but what's he going to do for the rest of the day? He's either going to be in his bed or a comfy, easy armchair, which is what we did here. What about shower chair? He would be spending an hour and a half on the shower chair in the mornings. So this shower chair had to have supports as well, and this one is a standardized shower chair, but we had to provide the external supports to accommodate his leg and feet contractures. Standing is very important for various physiological reasons and self-esteem. So what standing solution we can provide that best accommodates a person's posture and in the long run even tries to correct. So we looked at various solutions, and not only that, what postural aids and supports we can provide in a standing solution. So seating and mobility is a vast area, and making the right choice is a big challenge. There's a huge range of wheelchairs. There could be manual wheelchair, depending on manual wheelchairs that have numerous types, depending on whether it's a lightweight wheelchair, it's a medium weight wheelchair, whether it's a rigid frame or is it a folding frame? Is it a partial folding and rigid frame? Does it have a bucket? Does it need to have tilt in space function or a tilt or a recline? Power chairs, again, what control types you're looking for your patient. So you need to understand your patient, whether the controls are going to be chin control, head control, hand control. Now even we have eye gaze control. So you need to understand thoroughly your patient. And then the hybrid chairs, which allow function and mobility together. So chairs with power add-ons. So they are best, it's a good mix of activity and mobility and energy conservation. And then seat unit, what position in the seat is the requirement for the patient? Is it a standard seat? Does it need a tilt? Does it need bucket? And what foot plate types you're going to go for? Is it going to be folding foot plates? Is it going to be rigid frame? Is it going to be swing away? What angles of the foot plates you're looking for? Again, that depends on various factors. How are they going to transfer? How are they going to, if they're an active user, are they going to dismantle the chair and load it in the car, or somebody is going to push them? Tire types, whether they're going to use pneumatic tires or they're going to use solid tires. Casters, the front wheels, what types of casters are required, and what is the size of the casters that they require is at the stage of your assessment and And the recommendation is the person an active wheelchair user, or he's in between, where partly the person is active and partly dependent on carers and assistants, or are they fully dependent on assistants? Are you going to go for an attendant assist system? So it's a huge minefield to then choose the right solution that best meets the patient's needs, the care needs they have. Range of pressure cushion, again, it's huge, and it's a challenge to select the right one. So it depends on their level of injury, on how able or disabled they are, and how much risk is involved in terms of pressure. Can they do a pressure relief? Are they cognitively aware about their pressure buildup? Can someone do a pressure relief for them? If there are postural contractures and asymmetries, is it care-wise, is it easier for them to have any pressure relief, or they're going to be seated in it without pressure relief for a while? So all these factors will help a therapist to determine which type to go for. Their functional status and skin type. We sometimes use pressure mapping when we are too confused which cushion is best, but pressure mapping again is a tool to help make our decision. But our decision, we've gone through so many factors which are our decision making factors. Pressure mapping just helps to see whether, when they're static, is the pressure evenly distributed, and what material is best for them. There are air cushions, gel cushions, there are honeycomb cushions, there are custom specialist seating cushions. So I think it's a challenge for a therapist to then determine which cushion is most suitable from the huge range. And then specialist supports, what backrest are you going to go for? And the supports, how are you going to provide all that in one solution? Whether it's a tension adjustable backrest, again, it's a lateral support you want, whether you want a contoured support, whether segmental support. It again is based on what the patient requires and what is the funding available, what are the resources available. And then forming all that, knowing all that, we give a 24-hour posture management solution. So, which involves how they sleep in the bed. Sleep is how would they lay in supine position or sideline position? How are they going to change positions at night? How are they going to sit in the wheelchair? Is this the only chair they have? Because some patients would have indoor wheelchair, and then there's another one for outdoor purposes. Do they all meet their postural needs? Because they would be spending considerable time, 3 to 4 hours, in a device or in an equipment. So again, thinking about how they're going to stand, or are they going to stand at all? What is their posture like if they go back to work ergonomically? It's not just chair, but their environment around. And then you give a solution bearing that, all these things in mind. So as we said, 24-hour posture includes not only just wheelchair, armchairs, bed, standing frames, seating at work, driving. How are they going to be transported? Whether it's a power chair, manual chair, or in the normal seat. So, and then as a therapist, you advise them for each function. And very importantly, we have to involve the MDT, because posture management is everyone's business. Nurses, carers, when the patients are at home, family members, doctors, therapists, carers. If they are in school, then you have to involve the people around the individual at school. So it's a teamwork, and the team's roles changes from the stage of rehab they are in acute. Maybe it's more of a nursing, and the therapist is guiding in terms of education and setting up plan. And as the patient goes down their journey, it becomes more of an individual's and their care teams and family members' responsibility. So I cannot emphasize enough about educating the patients and making them understand what is the right and most appropriate and most aligned posture for them. we do a lot of teaching in front of the mirror, where we teach patients to understand when they're not sitting right. So that is an exercise, so that when they're in with their carers, they know how to instruct the carers. But again, there are limitations. Only those who are cognitively aware are able to do that, but there are patients who are not. So we have to teach the carers and the family members. Challenging. I think seating itself is a challenging job, and there's never a perfect solution. There's always a bit of a compromise. It's a compromise between function and comfort and the postural alignment. And it can sometimes it's a compromise between aesthetics, because it again depends patient to patient. Some patients are too concerned about aesthetics, and then we have to make we as it's a partnership. If we give a solution that the patients are not happy with, they are most unlikely to follow that. So we have to keep these things in mind, and likewise work with them. MDT working, I'm sure all of you will relate to this. It's never easy. Training people and training staff and ensuring that there is a consistency is always a challenge. Funding, yes, limited resources. I mean, we have the privilege for some patients to provide whatever is required, but in a lot of them, it is what is available, what funds are available, or what each service can provide to them. And yes, there's a huge range of equipment, and choosing the right one is always tricky, because and even if they're available, you cannot access them. So I find this very challenging. Patients' needs change, their functional needs change, and individuals with disability are living longer. So aging has its own impact, and many, many more, I am sure. But I think these are the things that we come across every day with every patient. So what can we take home from this crash course is that posture and seating solution, whatever we come up with, should maximize the residual ability of the person, minimizing their any secondary complications. We address basic questions. Is this posture energy efficient? Is it stable? Is it functional? And is it causing any bodily damage? We try to keep the solution as simple as possible, because there's less to go wrong. And balance and stable body is the foundation of functional skills. Thank you very much. And I can stop here and we can take questions.
Thank you very much, Shiva. That was great. I learned, well, there was so much I picked up there that I hadn't really considered before. So questions are already starting rolling through. Just to give those a little bit of time, if it's all right, I've got one or two myself. Is there a particular length of time when a contracture becomes fixed? You spoke about a patient that had arrived with you, a tilting space chair. Was that 6 months, and you managed to
yes
resolve that? But
no, we could not resolve it, and that is the thing. For 6 months, the patient was in HDU, and so the bones had fused by then. Now, this patient did have premorbid condition as well, so we're not sure whether he had a slight hyperextension of the cervical spine anyways. But contractures tightness can kick in within 6 weeks. And then from there on, if nothing is done, contractures will kick in. So, you know, within 24 hours, you will see the sarcomeres, which are the bodies that stretch the muscles and contract the muscles. Within 24 hours, there's about 10% decline in the sarcomere. So it says it all. You know, just in 24 hours of immobility, the physiological changes kick in.
that's excellent. That's very helpful. So questions coming in now from the audience. So Jacqueline, would you combine a seated corset with postural support?
Yes, I couldn't cover everything, but yes, we do combine seated corsets, whether they are hard corsets. It's a decision that we We take, along with orthotists, with the x-rays, whether it's going to be a hard corset or a soft corset. But something to be in mind, if a person is in active rehab, then hard corsets are a hindrance because they can't, the body is like a log. So with a lot of stroke and the spinals, we use soft corsets because that allows them mobility, because they're changing, right? So it allows them to be mobile and gives them support. So yes, we do more on the soft than on the hard.
And then a follow on from Jacqueline there. So what do you do if a client will not comply?
Yes, so we have to work with the client, and compliance can be various, whether it is aesthetics, they just do not like the bulky support you're giving them, they just want to be whether they want to be in a power chair, or you think they're good for manual chair but they want to be in the power chair. So it's always a negotiation, and compliance depends on how are you teaching and educating the patient. And in my experience, it changes over a period of time. It doesn't happen quickly. It's patients understanding their needs. And as a therapist, we are lucky because we're not just a seating service, it's a rehab unit. So we spend a lot of time with them. And as an MDT, if we're talking in the same tune, we managed to get somewhere. But yes, compliance is huge. And sometimes you have an ideal posture solution, but just patient is not compliant, or cognition. They're just not, they could be functional, but they are not because they are cognitively quite compromised. So you then have to, that's where your therapist experience and qualification comes. And you give a solution based on all the factors, including patient compliance. So it is paramount.
Thank you. It's very helpful. Shiva, quite a few requests coming through regarding the presentation. Would you be willing to
yes,
to
no
share
problem. I can. It's just that I might have to take some patient pictures out. So I will send you a version that can be shared.
That we can be shared. That's great. Really appreciate that. Another question here from Wendy. Do you use a standardized postural assessment?
Well, there is not a standardized. Oxford does their own. So our assessment form is based on the Oxford Center of Enablement, OCE, but it's kind of customized to our own needs because we have neuro and spinal patients. So it's a little bit biased to these conditions. But OCE has their own standardized version.
Thank you. And then another question in here. Please, can you expand on the 10% decline in sarcomere physiology, the 24-hour change?
So the sarcomeres is what causes the elasticity, the contraction and the expansion of the muscle, extension and contraction. So they need that mobility, they need that action time and again. And if that doesn't happen if a patient is on bed rest, that multiplication of sarcomere doesn't happen as quickly as it would if the body and the segments are moving. So that is what it means. Sarcomeres, don't get me on 10%, but this is I don't have a reference for that, but within 24 hours there's a considerable decline.
Thank you. A question here from Sarah. What would you do if someone extends at their hips when going into a wheelchair or a comfy specialist chair?
Stands on the hip means?
If somebody extends at their hips.
Extends, right. So extending at their hip, you have to see what the pelvis is doing, because it's a response to how pelvis is, how mobile the pelvis is. If it's fixed in that position, you have to accommodate. And if it can be mobile, it can go into tilt, then you try to get them in a near neutral position possible. So for a hip to extend, the pelvis needs to be anteriorly tilted. So whether that tilt is fixed or whether you can get them, whether there's an imbalance in forces that is making the pelvis just go into anterior tilt. So you have to see where is that extension coming from.
That's helpful. Another question here. Can you offer ideas for assisted pressure relieving techniques for individuals who are cognitively impaired and who cannot relieve their own pressure in a wheelchair?
Yes, so the what we use is leaning forward and leaning sideways. 2 minutes leaning forward and staying in that position, which is what is evidenced to it allows blood flow to in the weight bearing areas, which is the ITs, or leaning to sideways for 2 minutes. So that this is a standardized way of pressure relieving. You can use technology, you can use tilt in space feature of the wheelchair to give that pressure off the ITs. So, and if a carer is doing, this is what we teach the carers, that after an hour, they need to provide a pressure relief. Now, compliance is again a big thing because some patients may not like it. So then we go for what can we do in terms of cushion. Are we going to go for a high risk cushion, like Roho or air-based cushion, because they will then allow for some compromise and pressure relief for a period of time. But pressure reliefs cannot be replaced. They have to happen in lying, in sitting. So even in nighttime, pressure needs to be relieved. And that's why we have these systems, depending on how acute the person is. We have the Toto systems, we have the ways of patients changing their position, whether it's a nighttime care, or we also work on building the tolerance of the skin so it can tolerate a flat lying position for 4 hours, 6 hours, and then we build it up to 7 hours so they can lay in one position in that hour without skin breakdown. So there are various stages and various ways of managing that.
That's very, very helpful. There's a point here as well from Jacqueline. Dealing with the community is not easy. Even getting the MDT together, funding is a major problem. Excuse my ignorance. What is the MDT? It's
multidisciplinary team. And when we talk about multidisciplinary team, carers, family members, patient are part of those teams. Yes, it is. Things which are in our control is when patients are with us, or when they go in the community, then our best approach is to teach patients, teach the family members, teach the carers, and or any other bodies involved regularly with the patient, which are even the district nurses, because they manage the skin.
That's great. Another question that's come in. How do clients who work comply with research re-offloading every 4 hours as recommended by wheelchair services? They often find this impractical if an active user.
Yeah. Yes. Now we have to remember, if they are active users, they might not be that dependent and they are changing their positions. For example, if I say a stroke has full sensation, so you have to know whether the sensation is compromised in the areas which are weight bearing. So in case of stroke, it's not more so of sensation, it's more about are they able to move. In case of spinal injuries or MS, its sensation is impaired or actually absent. So we need to know that part. Active users, what we do here is, yes, it's 1 hour pressure relief is not practical, but over the time, it might not need 1 hour pressure relief because the skin has developed that much resistance, couple of hours. So in our experience, active users who are working do not do pressure relief every hour, but they're moving about. It's different thing. They're pushing, they're just shifting about. Those who are working with patients in neurology, you would see how fidgety they are. They keep moving because they are getting some sensory feedback of discomfort, and they have to move, not as effectively as a person without a neurological injury, but they still move about. So yes, over the time, even the skin develops that tolerance and can take load for longer than an hour. And what we teach to our patients when they leave us is having an alarm, repeated alarm, which just gives them a cue. It's time to pressure relief. So we can only make some strategies in for our patients.
That's great. A question here from Carol. When we introduce a sleep system, this would support their position through the night. Should we look at more than one system to enable position change?
So there is no hard and fast rule. We use combination of things. And sleep systems sometimes are not most, practical system, because somebody needs to remove the segments for them to change position at night. So it is very rare, I mean, in our practice, because we do not have so dependent patients. But yes, we use pillows, we use bits and pieces from other systems, because you are providing a bespoke solution. So no one formula works, a combination of things.
That's very helpful. And then question here from Harpreet. How important, in your opinion, is it for patients to see themselves in the mirror for posture management? Please, can you speak briefly on the science and benefits behind that?
Oh, yes. This is a part of patient education, because if and when they being in one position or posture becomes it becomes normal for them. So the concept of midline orientation just goes away. So you're teaching them what is normal for them and what is right. So which is a visual feedback. So yes, this is really, really important when we have patients, or when we're assessing a patient, when we set them up, you show them a mirror. Look, does this feel? And most of the time patients will, even when they're sitting straight, they would feel they're not, because they're quite used to being here. So it is important that, you know, you get patient on board and give them that teaching. It is as important as giving them an equipment, is teaching them. And a lot of our spinal patients actually have long mirrors, because they can then look at themselves and they can adjust, or they can tell carers how to adjust them.
Well, I think that's been really, really helpful, Shiva. Very much appreciate all the questions which have come in, and then your offer to share the slides afterwards. I think that's been really, really helpful. So just very quickly, in summing up, there's, as Shiva's kindly agreed to, there'll be her PowerPoint also on our site. We have a lot of free resources. So on there we have a seating ebook. There's lots of prescription forms helping you with writing justifications, training videos, and so on. So I'd really encourage you to jump on there, and it's free. It's yours for taking. And just lastly, in terms of our company change, you can see there, so that's what it looks like visually. So Yorkshire Care Equipment to Vivid Care. So don't be confused when you see Vivid Care. It's our new being as of Monday. So thank you very much again for joining us. Thanks all for your time. Thank you particularly to Shiva there. That's been very, very useful. Lots to digest and lots to go over. And thanks again to everybody for their time this afternoon. Have a great day.
Thank you. Bye-bye.